Sorry, I'm trying to get the title. Out of syllabus. We'll try to keep the presentation to about 8 minutes, 9 minutes, please, so everyone gets a turn.
Good morning, everyone. I am Dr. Lino, presenting on behalf of Medicine 3, out of syllabus. Presenting Mrs. Y, 25 years old, with the Bombay blood group from Mellur, presented with painful neck swelling for 7 days, fever for 5 days, and bleeding gum for 3 days. She was apparently well before 7 days, then developed painful swelling over left side of her neck, which is insidious in onset and gradually progressive, which is not associated with throat pain, then developed fever, which is high grade, intermittent, associated with chills. There is no history of cough, cold, abdominal pain, loose stool, or any rash. After 2 days, she developed painless bleeding gums, following which she is taken to a nearby hospital, found to have low platelet counts, and referred to higher center. Past history wise, there is no comorbidities, no previous history of any nosebleed, gum bleed, and EC bruising. Family history, there is no bleeding disorders in family members. Menstrual history wise, it is regular and normal flow. At time of presentation, examination revealed she was tachycardic with the pulse rate of 112, normal blood pressures and normal respiratory rate. Significant examination finding was noted tender posterior cervical lymph nodes, largest in the left level 5th group. Systemic examination was unremarkable. The differential considered at the point was fever with localized cervical lymphadenopathy. I don't have a slide. Fever with localized cervical lymphadenopathy. The differentials we considered were Epstein-Barr virus infection, CMV infection, toxoplasmosis, tuberculosis, and cat scratch disease. Lower in the down, we considered could be lymphoma and head and neck malignancies. The baseline investigation showed a total count of 2,000, platelet counts of 11,000, with hemoglobin of 8.2. Her liver function test and renal function test were within normal range, with a reticulocyte count of 1.63%. LDH were 434. At this point, we evaluated for fever with lymphadenopathy and pancytopenia. They can be divided into two based on the marrow. It can be etiologies can be due to hypocellular marrow or cellular marrow. Etiologies considered under hypocellular marrow was acquired aplastic anemia. The etiologies were drug-induced like NSAIDs, antimicrobial use like sulfonamides, tetracyclines. Other infections causing acquired aplastic anemia like same Epstein-Barr virus infection, parvovirus B19, CMV, other non-A, non-B, non-C hepatitis, HIV, HHV infections. Also, lymphoma involving bone marrow and acquired lymphoid leukemia. With the cellular marrow, the differentials could be autoimmune causes like SLE, HLH, sarcoidosis, nutritional deficiencies, vitamin B12, folate deficiency, and infections like tuberculosis and leishmaniasis involving bone. We did bone marrow for our patient on the day 1 and evaluated for other causes as well. The vitamin B12 folic acid levels were within normal range. She also had some iron deficiency component, like with total iron of 22 and total DABC of 271. Transferrin saturation was 8.11. Her blood-borne virus screening was negative. And for tumor lysis workup, we did calcium, phosphorus, and uric acid were in normal range. For HLH with ferritin and triglyceride, those were also not grossly elevated. We excluded most of the viral etiologies like parvovirus, EBV, toxoplasma, CMV, and we even repeated HIV ELISA after 1 week, thinking of acute seroconversion illness, which was also negative. Autoimmune workup done, ANA, dsDNA, C334 is normal. By the time our marrow reporters came as cellular marrow with trilineage hematopoiesis and adequate megakaryocytes. We also did a left cervical lymph node biopsy, turned out to be a necrotizing lymphadenitis, suggestive of Kikuchi disease. Kikuchi-Fujimoto disease, it's a benign condition characterized by cervical lymphadenopathy and fever. Most of the patients are less than 40 years. Etiology is unclear. Proposed associations are there are many viral infections and autoimmune conditions like SLE. Abnormal blood cell counts are the most well-known laboratory abnormality. The mechanism underlying cytopenia is probable mild myelosuppression. Usually the marrow will be hypocellular marrow. However, our patient had a cellular marrow. We thought we did the marrow at the time of recovery. This is a similar case report. The patient presented with PU and aplastic crisis. In this patient also had fever, cervical lymphadenopathy. However, this patient marrow was hypocellular. Diagnosis is mainly made by lymph node biopsy. Treatment is usually self-limiting. Spontaneous resolution occur in most cases. No specific treatment available. However, corticosteroids, hydroxychloroquine, and intravenous immunoglobulin as showed. Follow-up, these patients require periodic testing for development of autoimmune disease, particularly SLE. They may present along with the SLE, course of time they may develop SLE, so they need a close monitoring. In our patient, our patient is Bombay blood group patient. We didn't had any reserve blood bag in our lab. Day one of admission, we found her HB was dropping, along with she developed bleeding manifestation like hematuria. So after discussing with hematology, we decided to treat her with corticosteroids and TPO receptor agonist L-Trombopag. Role of L-Trombopag, the TPO receptor agonist, TPO receptor ligand thrombopoietin produced primarily in the liver, also in kidney and bone marrow, binds to TPO receptors on megakaryocyte, hematopoietic stem cell and platelets, thereby resulting increased stem cell proliferation, megakaryocyte differentiation, and increased platelet production. These TPO receptor agonists also bind to this TPO receptors and megakaryocyte, hematopoietic stem cells and platelets, thereby causing increased stem cell production, megakaryocyte differentiation, and increased platelet production. This TPO receptor agonist can also be used in aplastic anemia, ITP, and thrombocytopenia in liver diseases. Side effects of this TPO receptor agonist is thrombosis, hepatotoxicity, and rebound thrombocytopenia.
Yeah, any? Is Amit here? Would you like to add anything, Amit?
Whether are we sure if it is Pikuchi's disease? I would say no. We know that there is necrotic and lymphadenitis. It could still be an acute viral infection caused a marrow suppression. But when the patient with Bombay blood group and we had no reserve blood who came with an aplastic looking crisis with dropping hemoglobin, we had to start steroids, and we also decided to add on TPO. Thankfully, she did well. Another learning point here is that if we come across a patient with Bombay blood group, we should probably advise them to store their blood in a reliable blood bank and know a donor who they can contact in case of emergency. She did have rebound thrombocytopenia when she came back.
Okay. I think one of the amazing things that happened was that blood bank sent a vehicle to pick up somebody who was a blood bank, meaning Bombay blood group person, for the sake of donation. We had surgery going out of their way to getting the biopsy done. So I think teamwork and a lot of help from each other. Actually, that's the reason how we managed to make that diagnosis. Otherwise, but it does look like, I'll agree with Amit, it's probably a post-viral or a initial presentation of an autoimmune disease. We'll have to follow her up to see that. Thank you, Lino.